Okay, thank you very much for introduction. I'm Wang from PUMC Hospital in Beijing, China. Thanks to Matthias, give me the opportunity, and thanks to the host of Bangkok, Thailand. And today I will talk about the neighbor of lung, the heart, development of coronary CTA in China, and the applications and AI-assisted technology. First, we look at the global burden of cardiovascular disease and the risks. The cardiovascular disease, CVD, remains the leading cause of death worldwide, especially in Asia and Africa. But fortunately, Thailand is better than its neighbors. And the changes in, say, the mortalities in urban and the rural area of Chinese is still rising. The significant health damage and heavy economic burden makes early diagnosis and effective intervention of CAD very crucial. There are different imaging tools for detecting coronary artery disease, such as CTA, MRI, PET-CT, and invasive coronary angiography. Each has its advantages and limitations. For CTA, it's cheap and convenient, with high temporal and spatial resolution, with high diagnosis accuracy and absolute quantitative analysis. The MRI is free of radiation and has high soft tissue contrast. The PET-CT has high sensibility and specificity for some biomarkers. Invasive coronary angiography is still the gold standard for diagnosis of CAD. CTA as the first-line screening of coronary artery disease because it non-invasively provides autonomic and hemodynamic information of the entire coronary tree and the plaque, and with high reproducibility of quantitative image biomarkers evaluation. And why CTA dominates in China? It's costs less than the invasive modalities, and it's very cheap in China. The CTA costs no more than 100 RMB plus the contrast agent. That means almost $130 US, and it's covered by the medical insurance, and its sensitivity is relatively high compared with the invasive coronary angiography. And the single examination only costs 5 minutes. At the NPV nearly 100%. It can exclude the severe stenosis. And the clinical applications of CTA first is screening the high-risk population, especially systematic and atypical chest pain patients. And the plaque burden assessment, we need to detect the high-risk plaque. That means the vulnerable plaque. And the 4 signs we can get from the CTA is positive remodeling, a napkin ring sign, and low density plaque, spotty calcification. If 2 of the 4 signs is detected by the CTA, it suggests very high risk plaque. And third is the pre and the post-operative evaluation for the revascularization surgery plan and the stent and the bypass graft, also the heart transplantation evaluation. The fourth is the coronary artery variations, like the abnormal origin and the myocardial bridge detection. And the 5 is the myocardial assessment by the CTP and the latent enhancement, which can be an alternative of the cardiac MRI. Although CTA is very useful, the limitation of CTA is use the contrast agent that can have some side effects like allergy and renal dysfunction. So we still need the plain scan. The plain scan, we can get the calcification score. So it's a sign for the plaque burden classifications. In the CutRes version 2, a new P-level plaque burden classification has been added, including the calcification scores. It's recommended to use the standardized Agassiz score for calcification score quantification in clinical practice. And in reclassification of suspected obstructive coronary artery disease, the new guideline suggests considering calcification score for patients with a low pre-test likelihood of obstructive CAD to reclassify them and identify more patients with very low the score weighted clinical likelihood. And in atherosclerotic cardiovascular disease, ASCVD, risk prediction for statin recommendation. The calcification score is most commonly used in asymptomatic patients undergoing the risk assessment of ASCVD. The ACC and AHA primary prevention guidelines stated that the main purpose of calcification score measurements is to facilitate decision-making regarding the statin therapy. And last, I would introduce the implementation of AI use in the CTA. The AI-powered scan-to-point report full process coverage significantly reduce reconstruction and the reporting time to enhance the work efficiency. From the CT scan image process, plaque detection, and the stenosis evaluation until the film printing and the report, they can all be assisted by the AI software. The classification of cardiovascular AI applications includes the coronary segmentation and stenosis analysis, coronary plaque analysis, and the fat attenuation index assessment. Also, the coronary calcium scoring, the CT perfusion analysis, and the CT FFR calculation. We compared the AI and the manual by labor. The coronary automatic segmentation and the reconstruction only takes 100 seconds, but by labor it takes 8 to 10 minutes. And the lesion location, localization, and the stenosis detection can also be automatically done by the AI, with the sensitivity around 93%, specificity around 68%. The automatically reporting system reduced the total process time by 50%. And we, excuse me, we are developing the coronary plaque analysis software based on AI. And we want to classify the plaque as the stable and vulnerable. The 4 signs for the high-risk plaque, like the positive remodeling, low attenuation plaque, and the spotty calcification, napkin ring sign, we can use the AI tool software to detect it with relatively middle to high accuracy, around 0.7 to 0.9. The FAI, the fat attenuation index, quantitative measurement with the customizable range, it has high correlation of the FAI and the PET-CT TBR max. That suggests it can be the alternative of PET-CT to detect coronary artery inflammation. And then also AI takes very small, very little seconds to calculate the calcium score. And it only takes 30 to 60 seconds. And by labor, it needs 8 to 10 minutes. And besides the structure analysis, we can also do some functional analysis by AI, like CT-FFR and CT perfusion quantitative analysis. With relatively high accuracy of the CT-FFR, it achieves the 0.9 the diagnosis accuracy. And the deployment status of AI installation in China, it covered all China in mainland. The institutions about 5,000 has already been installed of the AI software, and more than 8 million patients has been tested. The usage rate is about 80%. In summary, coronary CTA as the first-line screening, it has the non-invasive nature, high diagnostic accuracy, and high cost effectiveness and efficiency, with broad clinical applications and comprehensive anatomical and hemodynamic assessment. Coronary calcification scoring is used to the CAD prevention, risk stratification, and the drug therapy decision. The AI integrations can significantly enhance the efficiency and accuracy of CTA examination with further enhance image quality, reduce radiation exposure, and expand the scope of clinical applications. That's all. Thank you for your attention.